great. Thanks so much, Kara. So I'm really happy to talk to you today about the Attach Parenting Program. The findings we have, some have been published and some haven't. And some are prepared as recently as yesterday. So it really is exciting to be able to share these findings with you. So make sure I can advance my slides here. Doesn't want to go. Next slide. So hang on. There we go. Oh, now advances twice. Okay. So the first thing I want to do is acknowledge all the wonderful partners we have established for this work. CIHR's funded us, policy-wise funded our early work. Alberta Children's Hospital Foundation did as well. The Harvard Center, the Developing Child Frontiers of Innovation program funded important components of what I'll be talking about today. And the Alberta Family Wellness Initiative has as well through the Palix Foundation. And I also want to definitely acknowledge the co-creator of Attach, Dr. Martha Hart, who helped me develop this in the course of her postdoc with me and continues to stick with us, firmly to this day, as well as Lubna, Anise, Virginia Xavier, Michelle Corner, Joanne Pekarsky, and a special shout out to Carlene Donnelly from CUPS, because she's been an incredible partner for a long, long time, and just delighted that she stuck with us through all this time as well. All right. So the outline for my talk is to speak about the theoretical foundations of the Attach intervention. We'll speak about attachment and toxic stress, parental sensitivity and responsiveness, reflective function. We'll talk about the Attach intervention, what it actually includes, what we've found in our evaluation of Attach, and also our ongoing and future work. So first, we'll speak about attachment. And when I focus on attachment here, this is the Attach intervention program model. And you can see we've got child attachment security down there on the lower left. And attachment is our ultimate interest, what we're trying to promote. Well, maybe not ultimate, but it's what we're trying to promote because it's so important to so many other things like healthy child development. So you can see it there in our theoretical model that underpins our program. But just to be really clear, there are some pop culture conceptions of attachment, and this is not what I mean about attachment. When people talk about attachment parenting, and they refer to things like letting children co-sleep until the children decide they'd like to move into their own room, or breastfeeding until the children decide that they're done. That sort of. That's not really what I'm talking about. So I just want to be really clear and make that distinction. And what I am talking about, though, is the concept of attachment in this context. And Donald Winnicott really helped summarize what I think is meant by the idea of attachment when he wrote this in one of his books. He said there is no such thing as a baby, and went on to say that there is a baby and someone, which is the most important thing about attachment, is that attachment is an evolutionarily based strategy that infants have in their biology that is designed for them to ensure the closeness of their caregiver to them, to ensure their safety and survival. So Donald Winnicott said that very well, and he's a UK psychologist and pediatrician who was working a long time ago when attachment theory was first developed in around the 50s. So what do we mean here by attachment? We're really focused on promoting secure parent-child attachment. And a key point that I'll make over again in this presentation is that sensitivity and parental availability are the key determinants of secure attachment. And secure attachment is a concept that includes these ideas that you see on the lower right. It's about this. It's about the parent's ability to be a safe haven and a secure base for the child. So the caregiver functions as a safe haven from distress or fear after a separation, and the child can use the caregiver as a secure base from which to explore the world socially and physically. And that comes from a history of knowing that their caregiver can be relied upon to have their back, be watching over them while they're out there exploring and trying things out for the first time in the world. And the things that children do to ensure that parents provide that safe haven and give them that secure base are demonstrate distress on separation, crying and fussing, that kind of thing that children do when their parents are away from them or leaving them, and do things to maintain proximity, making eye contact, grabbing their parents by the legs and those sorts of things, or, even crying in a way to get their parents to come close and provide for their needs. So these are the features that are important in when we think about what constitutes attachment, and when things are going properly or optimally, we're very much more likely to see a secure parent-child attachment. Okay, and I really like this diagram. It comes from the Circle of Security program. It's such a great diagram because it really explains the secure base and safe haven ideas quite well. So that safe haven idea is that the caregiver is there to protect the child, comfort them, delight in them, and help organize their feelings when they have been distressed or frightened by something in their environment. And that secure base on the top part of the oval is that reliable base that the child can trust will be there when they need it, and that supports their exploration. And the caregiver will be watching over the child, delighting in their activities and helping them enjoying things with you. And of course, the child can come back to the caregiver as they explore and go farther afield. They can come back to their caregiver to be that comfort when needed. And I think it's important to note, like secure infant attachment, we measure it between like 9 and say 28 or 30 months of age. And we find that, not just myself, but we, the scientific field, find that secure infant attachment predicts a whole host of great outcomes. So it promotes attachment security in adolescence and in adulthood, even though significant life events may shift attachment patterns, which I think is helpful to know. It suggests that attachment is not a static trait. Once it's established, all things being equal, it's very likely that the pattern will continue, but events can shift that for the positive or negative. And secure infant attachment also predicts more optimal relationships with peers throughout childhood and adolescence. And it's thought to be that the relationship qualities and experiences that children have with their caregivers are those that the children carry on into their relationships with their other children. So trusted relationships with caregivers translate to trusted relationships with peers. And also, secure infant attachment predicts children's social emotional development and positive behaviors like resiliency and curiosity and self-reliance, self-regulation, and social competence, even into adulthood, and just in general, overall positive mental health. In contrast, insecure infant attachment. So this is when things haven't gone quite right. The parent hasn't been that safe haven and hasn't been that secure base when needed. And the insecure attachment is what results. And when a child does demonstrate an insecure attachment pattern, it relates to children's externalizing behavioral disorders like aggression, behavioral problems, and antisocial behavior, children's internalizing behavioral problems like anxiety and depression, cognitive and language deficits, and adults' depression and suicidality. And what I think is maybe the most interesting is this recognition increasingly that insecure infant attachment predicts adults' inflammatory disorders and all-cause disease. And a great study was put out by Puig in 2013. I always like to mention it because they found that insecure attachment pattern demonstrated at 12 to 18 months of age in quite a large sample, found that those who were insecure were more likely to report inflammation-based illnesses and all types of physical illnesses at 32 years of age. So 31 or so years later, you see a strong association between the kind of attachment pattern children display and their likelihood of having health problems and even death at 31 years later. So there's in terms of the insecure attachment types, we have subdivided them into type A and type C. We think of secure attachment as type B, and insecure attachment has been divided into type A and type C. And type B is, as I said, is secure. And a nice way of thinking about that is B is for balanced. It's a pattern in which children are able to express emotions freely and recognize that their caregivers will accept their emotions and comfort them and those sorts of things. Where in contrast, a type A or a type C type of insecure child has different awarenesses of feelings than the more balanced type B secure children. So type A insecure children minimize awareness of their feelings and do what will be reinforced and avoid doing what will be punished. And for example, a child who's responded to negatively each time she cries may develop a type A strategy. In other words, type A kids are thought of as avoidant. They avoid the caregiver, and they also, you might think, avoid expressing emotion because that has not been responded to or regarded well in the past. So type A insecure infants often are thought of as being more inhibited. And in contrast, type C insecure infants they focus on feelings as guides to behavior. So in contrast to the type A, who minimize awareness of their feelings, the type C insecure children focus on feelings as guides to their behavior. And this can lead to the disorders of anxiety and obsessiveness tied to too great a reliance on negative affect. And so, for example, a child who is ignored by a passive parent unless they act out may develop a type C strategy. And so what happens is that the behavior that elicits the parent's response from time to time will be reinforced in the sense that the child will really act out because they're more likely to get that parent to respond to them. So the other thing about these type A and type C behaviors in insecure attachment is that the thought is that children of type A children's parents are more likely to be reliably disengaged, whereas type C children have parents who are more likely to be unreliably engaged. They may engage, sometimes respond to the child, and other times may not. And I'm happy to talk more about that later. And in terms of the normative distributions for attachment patterns, and so here on this little fan, you can see you've got the B types at the top. They're the purple and blue and teal. And then you have the A avoidant types, and you have the C types on the outside of the fans. And so the type A children, about 10 to 20% of the population will be considered type A. Fortunately, about 65% of the population is considered to be secure. With respect to type C, about 10 to 15% of the population is thought to be insecure, ambivalent, or resistant. There's different terms to be used. And then type D, which I haven't mentioned at all yet, is disorganized. And what is disorganized attachment? Disorganized attachment is an attachment pattern where the environment, the way we understand it, the environment has been so chaotic that the child is unable to develop an organized pattern, either a secure type or an insecure type. And it's described as plain old disorganized. And I really like, and I like and don't like the cover of this book, because it really displays what I think is the affect of the children who are disorganized. This child that I normally would call out and ask you, what emotions do you think this child is displaying? And if you want to unmute yourself and just tell me what you think the child is displaying in terms of emotion, I'd be happy to hear what you have to say.
Looks like bewilderment to me.
Bewilderment, yeah.
I see kind of a terror.
Terror.
Sort of terror,
Yeah.
like they just look like,
Yeah.
I have to be here. I have to be here, but I don't want to be here. It's
Yeah.
almost confusion, but he's not almost able to show it. So he's just like,
That's great. Thanks, Simone, and thanks. I think that was Angela.
And I would
nailed it.
add also that the child looks like they're not really being comforted by the fact that they're with the parent.
You've got it.
Like, yeah, like Simone said, I have to be here, but I'm not really getting the comfort that I need.
Yeah, you absolutely nailed it. So thank you so much. It's a very intelligent group, clearly. But the idea, the child's eyes are very over wide, like you would imagine in a fearful or anxiety provoking situation. And that's really at odds with the fact that the child should be comforted in the caregiver's arms. If you think back to that diagram I provided a little bit earlier, the caregiver is supposed to be that safe haven, that source of comfort in the face of distress. This child looks like it's distressed in the context of the safe haven, a very disorganized pattern. And so what does disorganized attachment come from? It's the way we understand it is primary caregivers, and of course, usually mothers, right? But the primary caregivers that are affected by toxic stress, and I'm going to talk to you more about what that means shortly, but affected by toxic stress, who may be traumatized, depressed, or distressed, it tends to reduce the regulation of the infant's distress because the caregivers are withdrawn, they're emotionally unavailable or frightening. And there's a strong association between disorganized attachment at early life and later problems, which include severe psychopathology, including borderline personality disorder, narcissistic personality disorder, and I've even seen research linking it to schizophrenic disorder. So the real point here, and I made it already, but I'll emphasize it, it's the idea that the environment is so chaotic, the caregiving environment is so difficult for the child to adapt to, that they become disorganized in terms of their attachment pattern to their caregiver. So I've talked about toxic stress a little bit, and I'm going to spend some more time talking about that now. You've probably seen this diagram before, but not all stress is considered toxic. There's positive sources of stress, the things that keep us doing the things we need to do every day. that, the kind of looking at your watch and saying, oh my gosh, I got to get to this presentation. That's a positive stress that enables you to do what you need to do. And then there's tolerable stress that are serious and temporary stress responses, but they're buffered by supportive relationships. So for example, say you needed to get to a meeting or something and you got in a little fender bender and somebody helped you at the scene and your partner helped picked you up and the insurance company helped you with your car. It's definitely a tolerable stress. And then, however, toxic stress is the kind of stress we're concerned about here and what we're concerned about in ATTACH, because it's prolonged activation of the stress response system in the absence of protective relationships. So it's only that type of stress that we're concerned, well, not only, but mostly that kind of stress that we're concerned about with ATTACH. And what are the sources of toxic stress? These are the three greatest ones: maltreatment or exposure to family violence, parental substance abuse, and postpartum depression. And these are things that the ATTACH intervention is focused on. The other one we're also focused on, and people often mention, is low income. So I like to always link the toxic stressors to the ACEs, the adverse childhood experiences work, because you can see right here, there's quite a lot of overlap between the adverse childhood experiences and the sources of toxic stress that the Harvard Center for the Developing Child identified. You see, for example, abuse, physical, emotional, and sexual. Well, witnessing violence between, so that's either maltreatment, one of the toxic stressors, but children can also be affected by witnessing, for example, the household dysfunction item, the mother treated violently, witnessing their mother being treated violently, and that's another source of toxic stress. Mental illness, that's just the same as the depression just spoke about as one of the toxic stressors in the Harvard Center framework, and substance abuse you see here as well. So a number of the adverse childhood experiences overlap very neatly with the toxic stressors from the Harvard Center for the Developing Child. And when we think about the impact of adverse childhood experiences, there are many negative outcomes. And this is why they're called, they're aligned with the toxic stressors, and why toxic stressors are indeed called toxic. They're toxic to children's development over the long term and health. And I have a whole other presentation that's also on the ATTACH Teachable website about the neurotoxicity of stress and how it relates to cortisol levels and that sort of thing, which I'm not going to get into this time, but it is available on the ATTACH Teachable site. So adverse childhood experiences or the toxic stressors are related to a whole host of risky behaviors like lack of physical activity, smoking, alcoholism, drug use, missed work, and physical and mental health. Everything ranging from obesity and depression and suicide attempts to stroke, cancer, and even broken bones. I've even seen research showing that adverse childhood experiences put people at greater risk for being in relationships that are affected by violence, that sort of thing. So you can start to see the intergenerational impacts of these. And just to show you some research that shows how the toxic stressor of depression undermines development. There's old research now, but I still think it's really great research showing that attachment security is undermined in situations where mothers are depressed. So if you look at the sort of, it's like a wine-colored segment of these pies. In the non-depressed sample, 70% of the children are categorized as type B secure in the non-depressed sample, whereas in the depressed sample, so these are children of mothers with depression in infancy, only 20% of those children are labeled securely attached, and that's the type B. And concerningly, 40% of those kids of depressed mothers are labeled type D or disorganized. And we see the same pattern into preschool age, with children of non-depressed mothers being far more likely to be securely attached than preschoolers of depressed mothers, who the difference is about 30% between the 43% on the pie on the left and the 13% on the pie on the right. And as you can see, again, that sort of yellow, much greater incidence of the disorganized attachment. So I want to talk to you a little bit about parental sensitivity and responsiveness, and how it is that the toxic stress gets under the skin to negatively impact development. And I talk about parental sensitivity and responsiveness, but many of you probably have heard the term serve and return that comes from the Harvard Center for the Developing Child and their frameworks metaphors. It's one of the ones that goes along with toxic stress. So really, that's a lot of what I'm talking about when I speak of parental sensitivity and responsiveness. But parental depression is a toxic stressor to parental sensitivity and responsiveness. That's how the toxic stressor, the child's not depressed. So how might it be that the child has all these poor outcomes? And there is a ton of evidence that parental depression leads to poor outcomes over the long term, just the same as ACEs do. It's in that same bucket. We see that depression in mothers reduces the maternal-child interaction quality. So they're less sensitive and less responsive with moderate to large effects. And they're more negative. They have more negative perceptions of normal infant behavior. So for example, baby fusses and a parent who's well might think, oh, it just needs to be comforted or needs a diaper change or something. Whereas a parent who's depressed might think, oh, it just wants to bother me again, for example. So they're less likely to pick up on infants' cues or respond to their needs. They're less emotionally expressive. The depressive symptoms just, make people less likely to be talkative or emotionally expressive. They're less affectionate and, of course, more anxious. It goes along with depression a lot of the time. So they're less sensitive and appropriate in their interactions. They're more negative in their play, saying no, don't do that, do it this way, those sorts of things. And they speak more slowly and less often. And so just to kind of connect this back to our attach theoretical model. So you see child attachment security there in the bottom left, and just to the right, you see sensitivity and responsiveness to child cues. So our thinking is that the more, not just ours, but sensitivity and responsive to child's cues improves attachment security, which in turn, if you go up the side of the diagram, contributes to healthy relationships and develop over the lifespan. And just to talk a bit more about, as I was alluding to, depression is one of those toxic stressors, and just use this example of how it impacts child health and development. Lots of research, that's what meta-analyses and systematic reviews are. They suggest that depression, postpartum depression in particular, has a significant effect on infants' cognitive and social development. These kids have more behavioral problems. They're more depressed, withdrawn, hyperactive, and aggressive. They have lower cognitive function and reduced verbal, perceptual, and quantitative skills. And it carries on. So as these children age, and even if their mothers are no longer depressed or their primary caregivers are no longer depressed, you still see them as having behavioral problems, being rated more difficult in preschool. They respond negatively to approaches by other children, and boys are more likely to be at risk. And as the children age, you see problems into adolescence at 12 to 19 years of age with internalizing and externalizing behavioral problems. So internalizing are things like anxiety and depression, and externalizing problems are things like aggression and hyperactivity. You see cognitive delays and substance use, and again, especially in boys. And you continue to see this as children age into adulthood with lower social functioning and depression and health-related stress due to poor physical health. And I also just wanted to speak briefly about the influence of another toxic stressor, the family violence on young children. When we dig deeper into the literature, more specifically, you see that you see the things below the blue arrows, many of the poor outcomes, behavioral and social emotional development, adjustment problems, trauma symptoms, cognitive development, and physical problems, all seem to be, they're all obviously related to experiencing or seeing family violence in early life. But when you really dig into the literature, you often see that insecure attachment in infancy kind of precedes these outcomes. So now I'm going to speak to you a bit about reflective function, which is really the focus, the proximal target, as we say, in the attach intervention. So going back to our diagram here, you see on the upper right, the high RF, that's high reflective function. So we're trying in the attach intervention to promote high reflective function, which underpins, as I'll show you, sensitivity and responses to child cues, which underpins in turn child attachment security and promotes healthy relationships and development over the lifespan. So toxic stress undermines reflective function, but what is reflective function exactly? So reflective function is defined as the parent's capacity to understand their own and their child's mental states, feelings, and thoughts. And this comes from the Steele group, who are they do major work in this area. And reflective function contributes to a parent's ability to regulate their own feelings and behavior toward their child, which may improve the maternal-child sensitivity and responsiveness, or parent-child sensitivity and responsiveness, and buffer the negative effects of stress, like intimate partner violence and depression on attachment and development. And so stress undermines reflective function, just as the other significant stressors do. So if you compare the unstressed brain to the stressed brain, it's interesting that under stress, neurologically, control of thoughts, emotions, actions, impulses, planning, and forethought, which are all essential to reflective function, are undermined as the prefrontal cortex is downregulated and the amygdala is upregulated. And the amygdala is responsible for processing fearful and threatening stimuli and events, and focus on threat detection and reacting with fear and anxiety and protective behaviors. So as a result, less neurological energy is devoted to the control of thoughts, feelings, and emotions in the prefrontal cortex, and more energy is devoted to reacting in the amygdala, with the amygdala dominating emotional processing. So this is what happens under conditions of stress. The prefrontal cortex is downregulated and the amygdala is upregulated, and it prevents people from having higher reflective function. So we're wanting to focus on higher reflective function in the attach intervention because higher parental reflective function is associated with secure maternal infant attachment. And as I've shown, secure maternal infant attachment is associated with better child development. So reflective function, I also want to point out Peter Fonagy. So Peter Fonagy was the supervisor of the Steeles, who really have done, Howard and Miriam Steele have really done the bulk of the work on reflective function. But it even goes back further to John Bowlby. John Bowlby is the father of attachment theory, and he connected reflective function to attachment as early as the 60s. And John Bowlby said that children's behavioral and emotional problems stem in part from a lack of parental insight into the motives underlying child behavior. And this is linked to poor parental sensitivity, responsiveness, and ultimately insecure attachment. So we're going back quite a long ways in history, 60 or more years in their understanding of this. And it's surprising that so few intervention programs like Attach have been developed to deal with this, actually, when you think about how long ago some of this has been theorized. And just to put reflective function in context for you, it's distinct from related terms like theory of mind, metacognition, mindfulness, empathy, and emotional intelligence, but it may tap into the same socio-cognitive system, but they're not the same as reflective function. And we think of reflective function as an internal ability rather than an observable behavior. But some people talk about reflective function as the operationalization of mentalizing, for those who might be familiar with mentalization theory. So parental reflective function, when we see it in parents who have high reflective function, they are able to think about their child as separate, autonomous individuals with, quote, a mind of their own. And they are able to imagine their child's thoughts and feelings. And they're able to perceive the influence of their emotions on their children's mental states. Parental reflective function is thought to strengthen the parent-child relationship. It underpins parental sensitivity, as I said. And, Bowlby was one of the first to say so. It's believed to support child development, and it plays an important role in the intergenerational transmission of attachment, which I will speak a bit more. Because if the child grows up to have healthy reflective function themselves, they're more likely to have healthier relationships and to be more sensitive and responsive to their own children in an intergenerational kind of way. So, and here we are. So now we've talked about high reflective function, which is the upper right. We've talked about sensitivity to cues and child attachment security and how that relates to healthy relationships and development. And at the top is really our intergenerational kind of marker here. If we can help people have realistic representations of mental states in each other, then they're going to have high reflective function, which, can have some intergenerational impacts. And just to speak a bit more about the difference between low and high reflective function and some examples from our own work about what this sounds like. And we do reflective function assessment either through an interview where we ask people about their, their experiences as a parent or their experiences with their own parents. And we also ask people use questionnaires, but the best and most well-regarded way of thinking and measuring reflective function is through interviews. So these come from some interviews we've done. So here's some examples of low reflective function. So we asked the parent, how do you think your angry feelings affected your child? And the parent replied, I don't think they made him feel bad. I almost guarantee that they almost give him a sense of accomplishment, that like my goal was to irritate him. And then another parent was asked, have you ever felt that you needed someone to take care of you or to be there for you? And the parent said, sure, yeah, of course I felt like I needed to be taken care of or feeling like I need some help. What was that like for you? I don't know. So these examples show not a lot of insight into either how their child was thinking or how they don't have much insight even to be able to explain how they felt in a given situation. Now, in contrast, here's some examples from high reflective passages in interviews we've had with parents. So the parent was asked, have you ever felt that you needed someone to take care of you or to be there for you? The same question as we just heard. And the parent says, yes, I was pretty upset that I was having to ask for support. I was frustrated and upset. So you see they're using emotional language here. They are able to label their emotions. And then the parent was asked, how did you handle your feelings at that time? And the parent said, I expressed them, I shared them, and made sure that I shared some ways that my expectations are not really expectations, but needs that could be filled. And so I kind of studied the problem, what I needed, and then I made sure that I just took some time to myself. So example provided here is really providing much more insight than the previous. And then another parent was asked, can you tell me about a time that your child felt rejected or left out? And their parent said, I knew she was feeling left out today. She said she wanted more time with just me. I think she felt alone. And I think it's really hard feeling no matter what your age, but it's especially difficult when you're not able to take care of yourself at all. And you're still dealing with all the, like there's so much more in childhood, all the feelings, they're bigger. And so I think anything that's good or bad for adults, it's a lot worse for her. So I think it breaks her anytime there's a little bit, just because there's so much sadder. So this example provides a lot of evidence that the parent has great insight into her child's thoughts and feelings and mental states. So high reflective function passage. And just to give you a little more insight into how reflective function, stress, and attachment function together. So when the child experiences distress or fear at the top, and it activates their attachment system, which means they're going to their caregiver for their comfort. They're using their caregiver as that safe haven, that haven from distressful stimuli. And they go to their parent to seek comfort. The caregiver should be able to comfort them and downregulate the child's emotions, right? So the child can go back to play and have, world where they feel safe and secure. But for that to happen, the caregiver has to recognize the child's, I spelled distress wrong, distress. The caregiver's got to recognize the child's distress, and they have to regulate their own distress. So say, for example, the distressful stimuli, a dog that runs up to the caregiver, and the caregiver is afraid of the dog as much as the child. The caregiver should first recognize the child's distress and then regulate their own distress so they can comfort the child. And if they're unable to regulate their own distress, that can be distressing for the child. And it goes back to that, the slide I had on disorganization, where the caregivers of children who are disorganized are often frightened themselves. That's when parents are frightened, that's frightening to children. Caregivers should be their safe haven. So this is an example of with the dog, maybe not the best example, but the example provided is to illustrate the fact that the caregiver needs to regulate their own distress so they can then down-regulate their child's emotions and have them return to exploring the world. And just turning now to some of the work we did early on as we were developing this attach intervention, we did a systematic review of the literature, and we looked at all the interventions that were designed to promote attachment security in children. And we found that the ones that were aimed at improving maternal sensitivity alone or in combination with maternal reflective function are effective. However, the most effective interventions seem to be the ones that did both. So that is what we attempted to do in attach. Oh, it's here, didn't realize. And so let's talk about the attach intervention. So the attach intervention model, as I've said, we have proximal and distal targets. So we're seeking to improve parental reflective function, that is the ability to recognize children's thoughts, feelings, and mental states. And our distal targets are the parental sensitivity, maternal child attachment security, and ultimately healthier child development. The attach intervention is a triadic parenting psychoeducational program. Triadic meaning it's the mother, or primary caregiver, the facilitator, and the co-parent, which I'll talk to you about in a moment. It consists of face-to-face, one-on-one attach intervention sessions and face-to-face triadic attach intervention sessions. So sometimes the intervention just occurs between the facilitator, the trained attach facilitator, and the parent. And other times it's the parent and their co-parenting support person, whoever that is. It could be the mother's partner, who is a father. It could be a father who's the primary caregiver and his best friend who's assisting with co-parenting. It's whoever that parent, primary caregiver, decides to be their co-parenting support person, along with the facilitator. And we designed it as an add-on program to existing parenting programs that do not emphasize RF, reflective function. And we planned that early on because we felt like there's many great parenting programs out there, but most do not emphasize RF. So we thought rather than reinventing the wheel and building another parenting program and just adding in reflective function, we would create one that could be added on to existing services and programs at agencies. And this came from some of our engagement work with community service agencies too, that seemed to be the way they wanted to go. And it's called psychoeducational, as I said. And so the attached interventions integrate psychotherapeutic and educational interventions together to assist the parent to develop reflective function. And also in the context of reflective function sessions, the support needs of the parents are addressed. And of course, as I mentioned, co-parenting support is acknowledged as very important. So our first aim is to foster parental reflective function for themselves. This involves helping the parent to develop the capacity to mentalize, recognize when mentalizing is lost, and restore mentalizing when it is lost. So again, showing how mentalizing terminology and reflective function terminology overlap somewhat. And then the second aim is to foster parental reflective function for the child and for the relationship with the child. And our third aim is to foster caregiver achievement of a realistic representation of their child and improvements in reflective function, which involves expressing sensitivity to emotion cues in the child. And as I've mentioned, we believe this, we know, as I'm going to show you in a moment, encourages the development of secure attachment and promote a whole lot of other great outcomes too. So the content of the intervention is 10 sessions with the attached trained facilitator. The parent determines the focus of most of what happens in the intervention. We consider stressful situations with them. The parent is encouraged to consider the thoughts, feelings, and intentions of herself and her child and others. The parent is helped to gain perspective by making sense of their own experiences and those of their children, their child and others. And if the child is not the topic, the child is at times brought back into the conversation, into the parent's mind. And we really want the parents to consider the emotional and relational needs of the child. So, for example, does the child enjoy this moment or not, or how can you tell? And the blue boxes at the bottom really indicate the three key parts of what we do in the intervention. We begin every session with a free play parent-child interaction video that is reviewed. And we select some moments in that video and talk to the parent about what their child was thinking or feeling in those given moments and what the parent was thinking or feeling in those given moments. And we also review these hypothetical stressful situations with parents. So for example, one of them is the family is sitting at the dinner table and the child throws her food on the floor. How does everyone think and feel? And then we also review real life stressful situations and talk about how people think and feel in real life situations. So I want to speak now about the results of our intervention. So we have evaluated it in 7 pilot studies, and they've been randomized controlled trial and quasi-experimental designs. And we've recruited mothers for pilot studies 1 to 3 at the Nurturing Parenting Program at CUPS Calgary or the TheraPlay program at Sunshine Women's Shelter. And you can see our sample sizes for these pilots were 20 and 10. And then for pilots 4 to 7, again, for RCTs and quasi-experimental designs. And we recruited here at the Nurturing Parenting Program at CUPS and the Developmental Care Program at Discovery House Women's Shelter. And our sample sizes here were 20 and 20. And so for these pilot studies, CUPS was the location for 1, 2, 4, and 5. Sunshine was the location for pilot 3, and Discovery House was the location for pilot 6 and 7. And CUPS promotes health education housing services, or provides health education housing services for families affected by toxic stress, poverty, and housing challenges in Calgary. And Sunshine and Discovery House are both second stage support agencies that provide shelter to women who have escaped family violence along with their children. So for pilots 1 and 3, these are the randomized controlled trials. So people were randomized to treatment or control group, and the control group did not get the reflective function intervention, the attached intervention. And what we found when we looked at our 3 measures of reflective function, we have one that looks at reflective function of the parent toward the child, one that looks at reflective function of the parent about herself, or in this case herself, and one that looks at parent-child relationship, reflective function about the relationship overall. And for all of those outcomes, we found improvements in the attached intervention group compared to the control group. The control group stayed the same from baseline to treatment for all of those outcomes. And for all those outcomes, the treatment group improved post-treatment, significantly so. I only show one graph here, but they all look the same. And then when we looked at the samples, just looking at within groups, this is the quasi-experimental component, we wanted to see if people improved themselves. When we compared them at baseline to post-intervention, did they improve? And we found on all the measures of child reflective function, mother reflective function, and overall reflective function, within the intervention groups, there was always significant improvement for the mother reflective function and the overall reflective function, but not so toward the child. But 2 out of 3 ain't bad, as they say. And so we're really impressed and pleased with that, and especially given such a small sample size. And we also analyzed the data on security of attachment in our intervention. And we found a trend towards significance with more children securely attached after the intervention. And we think we were affected by sample size there, which undermined our ability to find a significant difference in these small pilots. But I'll be sharing some information about new findings around attachment in a moment here. Now, with respect to pilots 1 and 2 as well, in the other outcomes, we found a significant difference between the treatment and control groups on the 3 measures of parental sensitivity and responsiveness, and measured with the Nursing Child Assessment Teaching Scale. And our effect sizes were quite large. That's what the D signifies here. A moderate effect size is 0.5, and we were just below that. A small effect size is 0.2. Anything small, medium, or large is considered good. So we're really pleased with that. But especially we're pleased for the children's social skill development, the ASQ. We had a very large impact on children's social skill development. And of course, the findings favored the attached group. And in pilot 2, we found significant differences between the baseline and post-attached intervention on 4 measures of parental sensitivity and responsiveness. So seeing improvement in the kids that just were not compared to the control group, just comparing people to their own performance before the intervention. And I just put these papers up here because all these findings are summarized in these papers if you would like more information about the sample size or whatnot. And then we did, this is a busy slide, but it's what we had to prepare for the Harvard Center for the Developing Child. They funded our pilot studies 4 to 7. And these are all the things they helped us to really refine. So I wonder if this should be moved here. Yeah, I guess I can move that. So we have strategies, which are all the program actions that we were doing with the families here, and then our targets. These are all the things we were trying to improve: reflective function, perception of social support, security, mother-child attachment, mother-child interaction quality, and our outcomes, improving executive self-regulation in the parent, reducing depression, reducing behavioral problems in the children, improving social emotional development and cognitive development and executive function. So these are things that we examined in the pilots 4 to 7. I'll talk to you about next. Oops, I want to go to the next slide. Here we go. So in pilot 4 and 6, I'm just going to focus in on the impacts here that are circled. We found that the children's fine motor skills were improved, which is really interesting, significantly improved. So when we compare the treatment group to the control group, the kids who were in the treatment group had better fine motor skills. And we found impacts on reflective function. That's the second circle here. PRFQ, interest and curiosity. That's a reflective function component. We saw that the parents had better reflective function as measured by a questionnaire. And then when we combine the data from 4 and 6, we still see the fine motor skills coming through, which is interesting. I've seen that in other studies too. And it's one you might not think of, but I think it relates to better development over the longer term. And then when we looked at 5 and 7, these are looking within groups. So within the treatment group, if we compare people's scores after the intervention to before the intervention, what did we find? And we see, again, improvements in parents' reflective function. We didn't do the interview this time, by the way, or the last time here. We just did this questionnaire, and we found significant improvements. And we found so many improvements in children's behavior. We saw reduced attention problems, reduced aggression problems, reduced externalizing behavior problems overall. We also saw a better executive function in the kids, and we saw better communication skills in the kids. And more. So this is when we combine the data from the 2 pilots, 5 and 7, we see the same kind of things again. We see better behavior outcomes in the kids, and better communication and problem solving in the kids. And so these little red and green dots are where we see, this is we had to prepare for the Harvard Center. So we had improvements in reflective function, that's a green dot. And then we saw improvement in behavioral problems, improvement in cognitive development. And for them, we didn't measure the attachment stuff. They didn't require it, but I'm just going to talk to you about that in a moment. But there was also a bonus activity that was done, and I acknowledge Harleen Sangera and Kara Ross for doing this work and really leading it. But with the, based on the pilot 6 data from the Discovery House, they wanted to know whether the attached intervention predicts better immune cell gene expression profiles. So lower inflammation, lower pro-inflammatory and higher antiviral gene expression in these families. And so they collected dried blood spots from mothers and babies and did this mRNA sequencing and assessed for this CTRA gene expression, and they did some modeling. And here's what they found. So I find it fascinating. They found significant differences in the CTRA index for the that showed that there were differences between intervention and control groups. And the mothers and the children in the intervention group had lower CTRA scores compared to mothers and children in the control group, as you can see here. And this means that mothers and children had lower pro-inflammatory and higher antiviral gene expression post-intervention compared to those in the control group. And if you think back to the ACEs studies and the attachment studies that I talked to you about earlier on, where attachment relates to inflammation, secure attachment relates to reduced inflammation and inflammatory disorders 31 years later. I think we're starting to see how it is that ACEs and attachment might actually create states that are either conducive to lower inflammatory disorders or more inflammatory disorders. And I think it's pretty exciting that attach could be one of those missing links in how we can help families and children have better outcomes, because we're reducing the stress likely, which is resulting in a better inflammatory response overall. And I also want to point this publication out, which summarizes all those findings that I just presented. And this is really hot off the press, but we have combined, as I was saying, when we looked at attachment as an outcome earlier on, attachment's harder to measure, so we didn't measure it in every single study. We didn't measure it always because it's so hard to measure, as I said. But when we combine the data from all 7 randomized controlled trials, where we have data on attachment pre and post intervention, what we did was find that attach significantly improved attachment security in the treatment group compared to the control group. And these findings were just shared with me yesterday. So really excited about this, and Lubna Anis, who's on the call, is going to be writing these up for publication. And what's really interesting is when I looked at these findings, I asked Lubna, I said, compare the groups at baseline. I want to make sure that these treatment and control groups are equal with respect to everything that might impact attachment at baseline. And she checked, and she found that they're equal with respect to everything like education and ethnicity and whatnot, toxic stress. But she found that the control group actually had higher reflective function at baseline on average than the treatment group. So they were advantaged. The control group was advantaged in this sample. Yet, even so, she controlled for that in the analysis. And even with that, she found that the attach intervention significantly improved more in the treatment group than the control group. So I think that's pretty interesting. So in conclusion, attach improves parental reflective function, parental sensitivity and responsiveness to cues, children's attachment security, children's health and development, and a range of areas, and immune function. And I didn't really emphasize this too much, but we also found intervention improved parents' immune function, which is kind of mind-boggling. And I think that we might be the first people to have noted that such an intervention could improve parents' immune function. And so with respect to our ongoing and future work, we have a lot of partners who've joined with us in the scaling and spreading of this program. We received $1 million or so from CIHR and our other funding partners. And we are working with the agencies we worked with before, Sunshine Community Services, Discovery House, and CUPS being most key, and have started to work with other really great partners like Steinbeck Family Resource Center and Marymount in Manitoba, and some great agencies, Sophia House and Regina Transition House in Saskatchewan, as well as the Family Resource Centers in Saskatchewan. So really excited to be sharing this work with them. And we have new agencies that want to join with us all the time too. Like we're hoping to work with Wynn House and also with Elizabeth House in Calgary. So here's our progress to date. We've got 67 people that have signed up on the Attach Teachable website to do the training. And we have had 38 Attach trainees that are engaged. And we've had 13 trainees now pass the Attach final exam. This is to become an Attach facilitator so that the intervention can be delivered in their respective agencies. And we've had lots of in-person training, and we're going to be doing a lot more. Martha and the team, Dr. Hart and the team, Lubna Anis and Joanna and Michelle are doing training, and they've done work here in Calgary with Discovery House and Sunshine Community Center in September, and they've done some more with CUPS. They've traveled to Manitoba to train in Steinbeck, and are going to be training more in Alberta and planning to do such training in Saskatchewan soon. And that'll be a lot of the focus for the next year. So one Attach trainees passed full certification, and so we have now I think we have about 5 master trainers, considering the master trainers we had trained before we started this $1 million grant. And 4 trainees have passed their administration grading process, and they're in the last phase of the training. And 6 attached trainees are in the are requiring just finishing one more training step prior to moving on independently. And I'm really excited to say we've begun data collection for this next phase. We're hoping to collect data from 100 families that will receive the attach intervention. And already we've got 3, we just started in the last 2 weeks. 3 attached study participants have completed all the pre-assessments, all the baseline data collection. And we've got 6 more scheduled. And so a total of 9 have been recruited so far, with more to follow in just over the last 2 weeks. And if you want to learn more about attach, you can go to our attach.teachable.com website. There's all kinds of information there, and all these presentations are reposited there as well. And so I just want to say thank you. And I'll be happy to take questions. And I always like to just put my books up here. A lot of the research I've spoken about and more, way more, is included in these books. So I just always like to suggest some resources for everyone. So with that, I am finished. Thank you.
Thanks very much, Nicole. I'm sure applause all around. Thank you very much for this. So we already have a couple of questions in the chat, so I'm going to jump directly into the questions then. And there's lots of applause coming up, so thanks very much. So the first question is from Angela. Great presentation. How are the results of less behavioral disorders measured? As well, is there a plan to follow the groups into adulthood to measure behavioral improvements or personality disorders in children and parents at risk?
Yeah, that's a great question. Well, we measured the behavioral problems with the child behavior checklist. That would be the number one. We also use the brief to get at things like executive function, which is not really behavioral, but more just a developmental outcome. So the child behavior checklist is very well regarded as a measure. And so it was nice to be able to link our findings to, you know, those of other scientists around the world who've evaluated parenting programs. And your second question, well, if we have funding to follow these kids, sure. So it's always the funding limitation, but absolutely, we'd be very interested to see if this intervention goes on to have longer impacts. That's really the holy grail, isn't it? I mean, we hope that we're not just having impacts in the short term.
Thanks. All right, we also have another question from Susanna. Nicole, were the pilot groups that did not receive the reflective function in the beginning given reflective function training afterwards? And please explain what the CTRA is again. I think I can answer that second question if you want to.
Yeah, that would be great. That would be great. Thanks. So I'm just going back to this slide here where the pilot groups that did not receive the RF in the beginning given RF training after. Well, this is exactly how we designed our study. So we've got attached pilot 1, we just 20, and then we broke them into intervention and control groups. And you see this control group, they get the intervention after. So what ended up happening is we have this RCT component, randomized controlled trial component, then we have this quasi-experimental component because we would measure the control group outcome after this wait period. They were waiting while the intervention group was finishing up. And as soon as it finished up, they had some measurement done again. And then we gave them the intervention and then they were measured again here. And so we did that. We didn't do that for pilot 3, but we did that for pilot 1. And then we called this pilot 2, which is the group that gets the intervention next. And then we did that same thing in the pilots 4 to 7. So pilot 5 and 7 are exactly what you're asking about. The control group got the intervention. So that's kind of why our design is a little bit complex, but we couldn't in good conscience not deliver something we thought would be effective to everyone.
I was just wondering, you know, to help the parents, to help the parents go forward. This is such a valuable tool. So yeah, I'm really glad to hear that you did offer it to them afterwards. Yeah, that's good.
And just an FYI too, in our work that we're doing now, the latest recruitment of the 100 families, and you know, when I spoke of the progress to date, there's no control group anymore. We are just delivering the program. I mean, the findings, there's significant findings everywhere we look. This program seems to be effective. So I couldn't in good conscience do more control groups. And we also want to, a big part of our program delivery that we're trying to do now is make it so that it's more like what agencies are already doing. So agencies don't have control groups, agencies have programs. So we're helping them just learn to do the program and deliver the program and actually collect data on the program. because we still want to know if it's effective whenever it's delivered, wherever it's delivered into the future.
Oh, great. I'm so glad to hear that. Yeah.
Yeah, thanks, Susanna.
And then for the CTRA, just quickly, so in a nutshell, it's kind of a stress fingerprint that shows up in your immune cells. So people, and it's from Steve Cole is faculty at UCLA. This is his baby, and he's discovered that when you expose people to stress or adversity, broadly defined, you see changes in how their immune cells seem to regulate themselves. So there's this shift, this fingerprint shift towards pro-inflammatory activity and less antiviral activity, which is associated with a slew of risk factors for disease down the road. It's like your immune system is starting to get revved up in preparation to deal with whatever adversity you are currently dealing with. So yeah, that's what the CTRA, because we thought that this was going to be, these are families that are coping with a lot of adversity. We decided to take a look at that fingerprint specifically because it seemed that if we were going to see any movement, that's where we would see it in the immune cells.
That's really fascinating. Yeah. I mean, you could use this in almost any setting. And also, how soon does that fingerprint decrease? Like, do you see this reduction of this immune stress response in the inflammatory sense? Do you see it go down? Like, what was that time frame that you actually saw it reduce?
So that was a 10-week intervention, Nicole?
Yeah, 10-week intervention.
Yeah, so in 10 weeks, you could pick up that difference. So it's one of those interesting measures because it is flexible, like it responds to change in environment, but it can also have some long-term implications for disease and health down the road. So yeah.
Do they think that what happens is it gets set at a higher base level if a child is continuously under toxic stress? And so that in a sense that would set them up for these diseases long term. So in other words, their system is always kind of running at a higher level. It's always kind of having to deal with some kind of response that it can't, like, there's no resolution to the stress. It just kind of keeps it. So does that kind of change the whole physiology? Do they think that's what's causing the down the road disease?
Yeah, so the theory goes that your body is going to go through short-term adaptations that can have long-term consequences. So if you are living in an adverse environment, for example, having an immune system that's ready to go, whether that's for injury, risk of infection, anything like that, that could be really helpful and beneficial, like to coping with those circumstances. The problem, though, is that the immune system is very powerful and it has a lot of implications for a lot of other physiological processes. So if you have an immune system that's always primed for activity, the problem is that down the road, it could start either reacting to the wrong things, or it could be having an overactive response, or it could just start wearing itself down and start responding inappropriately. So it's one of those interesting things that, in the short term, like I said, in a dangerous environment, it might actually, well, potentially from an evolutionary perspective, more dangerous environment, having that immune system ready to go is good. But yeah, it can potentially cause issues down the road if it stays at that high level of maintenance.
Okay, good, thank you. It's very interesting.
It'd be interesting to see if how it translated into different cultural settings for those that are, in afflicted areas. When you go down to people who are in war zones or who are in long-term situations of very high stress, does it completely change then how they, that's basically what you're saying. It's going to completely change how they respond to everything. It's kind of an interesting marker to find.
Yeah, and it's still like we looked at it here, but Steve is still doing his own research in terms of how it goes. But like he's looked at like the adversity that we look at here. He's looked at loneliness. Like it doesn't seem to matter how you cut it. This pattern seems to come through, and that's why it's called the CTRA stands for Conserved Transcriptional Response to Adversity, and it's because it seems to be conserved across adverse experiences. Yeah. All right.
Could you just
another question?
Could you just type that out, that whole CTRA, just so I have the name?
I will do that. Let me introduce Maeve's comments first, and I'm also want to be aware of the time. So does this mean that attach could decrease hospitalization and death from COVID? And would there be a way of looking at this from your data?
Wow, that's a good question. Our sample size wouldn't be big enough, I'm sure, to be, make real claims about that. And I'm not sure how powerful this conserved transcriptional response to adversity index is. In turn, I don't know, Kara, you probably could comment more on that. Like, do you think it reduces your likelihood of getting colds? Like tell me, or coronavirus?
I'm sure Steve's working on this. I haven't seen any work on it just yet. I know, actually, I think that if I'm remembering this correctly, they have found that it relates to your risk for viral infections. So it is possible that it could be related. What now in the context of COVID, I can't comment.
Yeah. I mean, for me, I like to just think about, okay, we've seen associations between ACEs and inflammatory disorders across the lifespan. Everyone has seen that. Everyone has seen that. And yeah, and people also talk about how serve and return is protective, right? It's going to actually protect children from the impacts of toxic stress. So I feel like Kara and her team have kind of tapped into the mechanism. So we're promoting serve and return because we're helping parents be more thoughtful and reflective about what the kids are thinking and feeling. And so they're more sensitive, they're improving their serve and return, they're doing the buffering of toxic stress. So actually at a very mechanistic level, tapping into how it is that toxic stress creates inflammatory disorders over the lifespan. It's about parenting. And I mean, people might not want to hear that, but I think it's also very powerful. If we can just help parents buffer impacts of stress on children, their inflammatory systems might not go into, overdrive, and it could protect them over the longer term, not just mentally, but physically. And I see you there, Mae. Did you want to make a comment?
Yeah, just think of all the places you could go for funding if you could come up with a theory that this might actually work to decrease some of what's going on.
Well, that's what we got, how we got funding, I'm sure, this time around, because we're going to be doing dried blood spots on all 100 kids. And we're really looking to see if this intervention does continue to show the same trends. And we'll also do, if we can, we'll do larger epigenetic kind of studies, look at methylation and see if, and because of some of our other work, which I didn't talk about at all, but Kara, your work has shown that distress in mothers changes methylation patterns in children that put them in areas that are related to inflammation. So in distress in mothers is a toxic stressor, right? Which undermines relationship quality. So we think this is the mechanism. It's about, we're actually just demonstrating what everyone is saying, but no one has been able to show with a randomized controlled trial.
But maybe you could just add like an illness diary or something to what you're doing already that might help get, it won't reach significance or anything, but it might help you lay the groundwork for the next grant that says, hey, we're looking at illness and whether this actually makes a difference.
So a nose diary, is that what you called it?
An illness.
Oh, yeah.
Illness diary.
Say that, Kara. It was kind of cutting out, so I'm not really sure what we should be adding. But I want to know.
It sounds like it might be similar to that allergen questionnaire where it asks like, how often did your child get a cold? How often, like the sickness, frequency of sickness. Yeah.
Yeah, we've done that in our other work in vid kids. We have like a score. We actually look at skin conditions. The atopic march. We look at skin conditions in children that relate to things like respiratory and asthma kind of problems over the long term. We're at early stages maybe, so it's a really good suggestion, and it might be something we should add. We should definitely be talking about that because we won't have missed any opportunities at this point. That's a great suggestion. So let's put that. Let's talk about that, Kara, and Martha, put that on the agenda for our next attached meeting. I think that's a great idea. Anything we could do to get more funding?
I just have one last question. I know we're over, but how does it improve the child's fine motor skills? Is that because the brain is more calmer and they're able to focus? Like, what is the reason that the fine motor skills?
I don't know what the reason is, but I've observed this myself over the years. I remember one of my very first studies I was a research assistant back, like this is in the 90s. And I was doing a study with someone as a research assistant, and we were helping parents with crying babies. And we helped the parents by I'll try to be quick, randomized into treatment and control group, and the treatment group got intervention around being more sensitive and responsive. It was like carrying your baby, massaging your baby. Wasn't what we're doing, but it's very related. And I kept going into these houses and I would see, and I do my assessment because that's what I was my job. And we didn't measure it, but I would see these kids had better motor skills. The ones who were getting the treatment had better motor skills. And I mean, I'm not a motor expert. I probably asked Deb Dewey actually about this, Kara, but I suspect that when parents are more engaged with children, they're playing more with them, they're using toys, and it builds their fine motor skills. And as I said, I haven't studied it, and I probably should go and look when we write this up. We haven't written up those findings yet, but when we write them up, I'm going to look at the literature and see if there's anything to that observation I've made for years and years. Yeah.
Cool. Thank you.
Great. Yeah. So we still had a couple of questions. Simone had a question about theory of mind and autism, and Nicole, I think if you'll reach out to her offline, I think just because I want to be aware of time. And
Yeah.
Angela also asked a question about hyperimmune systems and epigenetics, in relation to Indigenous families. That might hopefully be a question we might be able to address here. I am not familiar with a lot of work there, Angela, just because researchers are not great at engaging with Indigenous communities right now. So I don't think there's a ton of information out there at all speaking to this, even though it's very important. But I'm going to stop it there because I love the conversation, but I want to make sure we stop on time. So just before we wrap up, Nicole just was going to tell us briefly about we're going to have another attached webinar starting in January, same time, same place. And Nicole's just going to quickly tell us about our first person in January.
Yeah, we're really delighted to have Nancy Mannix present to us at our next session. And she's kind of an in-demand sort of international advocate for the importance of early childhood experiences to better developmental outcomes. And she's the chair and patron of the Palix Foundation and the Alberta Family Wellness Initiative, who have funded some of the original work that we presented today. And so she'll be speaking. Her topic is called Strengthening Resilience in Times of Adversity, a tool for clinical practice. And she's going around and speaking to lots of groups about it. And so I was really delighted when she offered to speak to ours. And I really urge you to attend. She's a dynamic speaker and has done a lot of great work in this area. And I really hope we can get a large attendance, larger than mine today. Everyone's heard about my stuff before, but I would really love it if you could get the word out and get as many people as you know to come and join for that. So it'd be great. And there's Caden.
Yeah.